Good afternoon, everyone. Our lesson for today is about genito-urinary trauma. So let's begin with the first organ, the genito-urinary system, the kidney. So the prime goal of renal trauma is to preserve its function, okay? The kidney function. So largely, it is non-operative in modern times, especially in the setting of low to intermediate grade renal injuries from a blunt mechanism of action. So the role of angioembolization through vascular and interventional radiology has further increased this non-operative management. The first goal is to accurately grade the renal injury. So the gold standard to test and to diagnose and stage a renal injury includes a CT scan with IV contrast with delayed images. So in most centers, this is referred to as CT urogram. So a delayed contrast imaging delineates the upper urinary tract collecting system. So the criteria that would mandate renal imaging include the presence of, first, gross or microscopic hematuria with hypotension, mechanism increasing the prevalence of renal injury, sudden deceleration injuries, flank contusion, etc. Renal trauma management depends not only on the grade, but also on the injury mechanisms and clinical symptoms. So absolute indication for surgical or radiological intervention includes life-threatening hemorrhage, renal pedicle avulsion, or pulsatile or expanding retroperitoneal hematoma. Penetrating renal trauma with a retroperitoneal hematoma should undergo exploration when hemodynamic instability exists. In a hemodynamically stable patient, it should be initially observed. So conservative management entails rest and hemodynamic monitoring. So patients with grade 4 renal injury should be treated in the same manner. And a repeat CT scan or CT urogram should be done to make certain that the urinary extravasation has resolved. So urinoma and subsequent abscess formation may occur. If urinary extravasation is persistent, placement of ureteral stent or nephrostomy tube should be considered. So these are the renal trauma grading system. So for grade 1, the description includes a contusion or a non-enlarging subcapsular perirenal hematoma. So it's only a contusion, no? It is managed conservatively by monitoring and serial CBC. So perinephric hematoma without obvious parenchymal laceration on CT or less than 1 centimeter laceration into the cortex of the kidney is considered grade 2. So generally managed conservatively in a stable patient, same as grade 1. So for grade 3, it is already more than 1 centimeter laceration into the cortex without involvement of the collecting system. So same management for grade 1 to 2 and 3. For grade 4, a deep laceration to the collecting system with evidence of urinary extravasation on CT, with evidence of urinary extravasation with segmental renal artery or vein injury with contained hematoma or partial vessel laceration, or also vessel thrombosis. So it can be observed expectantly in a stable patient, but may require subsequent or urgent delayed repair for patients needing it. So renal arterial embolization may be an option for those who fail conservative therapy. So for a grade 5 renal injury, renal pedicle injury or multiple renal lacerations are observed, or it's considered a shattered kidney. So the management patient requires often surgical exploration, but stable patients with only parenchymal injury may be safely treated conservatively. So this is how it looked like. As a normal kidney, here, the grade 1 injury with already a perirenal hematoma, grade 2 injury with hematoma and also a less than 1 centimeter laceration, grade 2. Grade 3 injury, there's already a more than 1 centimeter laceration. It could be also hematoma, with concomitant hematoma. Grade 4, already a more than deep laceration, and could be an laceration on the collecting system. And the grade 5 is a shattered kidney. So the early vascular control may minimize nephrectomy rates. So this is accomplished by isolating the renal vascular medially prior to opening the perinephric hematoma. So if uncontrolled bleeding is encountered, once the hematoma is opened, occlusion of the renal vasculature can be performed. So renorrhaphy can be safely done, as can a nephrectomy in the setting of a grade 5 renal injury. So here are images of renal trauma. So here, as you can see, a CT scan showing hematoma formation with extravasation of dye with resultant laceration. Here, there's also a hematoma and injury to the collecting system. So there are also images here. This is also an angiography showing non-vascularization of the lower pole of the kidney. And here are some figures on how to repair it. Like they do partial polar nephrectomy with omental patching, with a pedicle flap, and also renorrhaphy. Our next urinary tract system is the ureter. So urethral trauma, there's no association between the magnitude of urethral injury and the degree of hematuria that is present. High index of suspicion is required for this type of trauma. So diagnosis requires either a CT urogram, an IVP, or a cystoscopy with retrograde pyelogram. So IVP means intravenous pyelogram. So unlike renal injury, the ureters are more commonly injured through a iatrogenic mechanism. So common surgical procedures in which the ureters are injured include gynecological, colorectal, and urological surgeries. The repair of ureteric injuries depends on the time of identification from initial injury, location, and length of the injured ureteral segment involved. So here are examples. Ureter obstruction model. So here it could be an injury here in the proximal ureter. As you can see here, there's an extravasation of the dye and non-passage of the dye through the whole length of the ureter. Probably this one is a second model, is a crash model, and this is a complete transection model. Iatrogenic ureteral injuries should be initially managed with ureteral stent placement when possible. So when stenting is not visible, open repair may be attempted when the patient presents shortly after injury. So when stent placement is not visible also, or when present, nephrostomy tube also could be an option. No? So ureteral injuries of traumatic origin should be repaired during the index admission when possible. Hemodynamically stable patients undergoing laparotomy for other reasons in which a high index of suspicion of ureteral injury is present should have ureteral exploration. So stable patients in the same situation that are identified to have a ureteral injury should have a primary repair at the time of exploration. So if patient is hemodynamically unstable, on the other hand, the ureter can be ligated with subsequent nephrostomy tube placement, and a delayed ureteral repair can be done once the patient is stable. So here are some examples of repair. So this one, if there's an injury in the upper proximal ureter, direct ureterostomy can be done, or transureteroureterostomy. So direct ureterostomy is just like repairing it and reconnecting it. The second one, transureteroureterostomy, would be to connect this part of the ureter to the other side of the ureter. If, for example, the distal side is already necrotic. In the middle, you have middle ureter, you have an option of direct ureterostomy. You can put them together, or another option would be the same as the upper. You can connect it to the other side. However, in the lower or in the distal, either you do ureteroneocystostomy or reimplantation, excuse me, or a psoas hitch. The definitive operative management of ureteral injury depends on the location and extent of devitalization. So it is important to debride devitalized ends of the ureter, whether it is from a contusion via a gunshot wound or an iatrogenic thermal injury. So upper ureteral injuries that are short can generally be resected and anastomosed primarily. So ureteral mobilization with preservation of the ureteral adventitia to maintain vascular supply can aid in bridging short defects. So in modern times, more aggressive maneuvers to direct anastomose more proximal ureteral injuries to the bladder are possible. Maneuvers used to bridge the defect of ureteral length for direct anastomosis to the bladder includes bladder mobilization with ligation of the contralateral bladder pedicles. You could do a psoas hitch, tacking the bladder down to the ipsilateral psoas tendon, or a Boari flap with downward nephropexy. So Boari flap, you create a flap from your bladder wall, and then you put the kidney downward. That's why it's downwards nephropexy. You relocate it. So the next is when bladder to ureter anastomosis is not possible. With these maneuvers, the remaining options include transureteroureterostomy, connected to the other side, creation of an ileal ureter. You harvest an ileum and make it as a ureter. Renal autotransplantation to the pelvis, or you retransplant your kidney to the pelvis, connecting to the common iliac, and ureteroneocystostomy, or connected to the bladder. Next is bladder. So bladder can be injured through iatrogenic and classic traumatic mechanisms. So indications for bladder imaging include gross hematuria and the setting of injuries with correlation to bladder injury. So the most common clinical scenario is gross hematuria associated with pelvic fracture, so which is associated with 29% chance of bladder laceration. So diagnosis of bladder injuries requires a CT cystogram or a fluoroscopic cystogram. So the sensitivities and specificities of these two modalities are similar. The bladder should be filled with at least 300 cc of contrast for either of these imaging modalities. So contrast may be visible at the site of injury, so within the peritoneal space or in the perivesical space. Simply capping the Foley catheter alone on a delayed excretory phase of abdominal CT imaging is insufficient to diagnose a bladder injury. So here are the different types of bladder injury. So if it's contusion, it's type 1. If there's intraperitoneal bladder injury, it's type 2. Type 3, if there's interstitial urinary bladder injury, simple extraperitoneal rupture is type 4A, and combined intra and extra is already type 5. So the type is also different from grading. So if there's a The grading for trauma, once it's hematoma, contusion, or laceration with partial thickness, it's already grade 1. Grade 2, laceration is extraperitoneal, which only less than 2 cm. Grade 3 is more than 2 cm extraperitoneal and less than 2 cm intraperitoneal. Laceration intraperitoneal more than 2 cm is already grade 4, and extraperitoneal extended into the bladder neck or urethral orifice or trigone is already grade 5. So from grade 3 to grade 5, it's already surgical. So intraperitoneal injury requires repair during the index of admission after the patient has been resuscitated. Delayed repairs associated with abdominal sepsis. So repeat cystography should be done 7 to 14 days prior to Foley catheter removal to ensure that the laceration or operative repair has healed. So extraperitoneal injuries can generally be managed with Foley catheter drainage alone. So operative repair include complex injuries involving bone spicules from a pelvic fracture within the laceration and concurrent rectal or bladder laceration. So bladder neck injuries also may be treated operatively during the index admission, as these injuries occasionally do heal with Foley catheter drainage alone. Next would be urethral trauma. So the common mechanism for urethral trauma is a pelvic fracture. Associated injuries, it occurs at the level of the membranous urethra. So in stridal injuries, it usually occurs at the bulbar urethra. So the clinical hallmark of urethral injury is blood permeatus. So our RUG or retrograde urethrogram should be done when this is present to diagnose an injury prior to the attempted Foley catheter placement. So here is the anatomy, as you have already learned. So in male, there are 4 parts of the urethra. It's also divided into 2, the proximal urethra and distal urethra. The proximal urethra is further divided into membranous and the prostatic urethra. The distal urethra is divided into bulbar and penile urethra. The initial step for urethral trauma is bladder drainage to prevent urinoma formation and subsequent abscess formation. So in general, this is accomplished through placement of a suprapubic tube. If patients are managed with suprapubic tube alone, the site of disruption leaves the patient with a urethral stricture and subsequent restructuring. So after stabilization, some centers perform primary realignment. This is a dual antegrade and retrograde endoscopic procedure utilizing fluoroscopy to bridge the urethral defect to place a Foley catheter across the injury. It's like connecting from the bladder, going to the urethra, and connecting them to realign it. Subsequent restructure rates are high, but the severity of stricture formation may be less when primary realignment is performed. So penetrating injuries to the anterior urethra are rare. In a hemodynamically stable patient with uncomplicated injury, it is an expert opinion to perform exploration with primary repair during index admission. So complicated injuries with extensive tissue devitalization should be managed with suprapubic tube, urinary diversion, and delayed reconstruction. So there. So the next would be external genital trauma. So first would be penile fracture. So it classically occur with excessive torquing of the erect penis. So rupture of the tunica albuginea, which could be heard as a popping sound, can be experienced. So common symptoms include immediate tumescence with subsequent development of a hematoma. So clinical history and examination alone are sufficient to warrant surgical exploration with primary suture repair of the corporal body laceration. So this is how it looks like. So there will be a formation of hematoma, and the formation, there's a deformed penis. And when you explore that, there will be a laceration on the tunica albuginea. Penile fractures, for equivocal cases, ultrasonography or MRI may be done. So up to 10% of penile fractures are associated with urethral injury. So blood at the meatus signifies the possibility of a coexisting urethral injury. So prior to repair, you should make sure that there's no urethral injury to, you could do an RUG. So, or cystoscopy at the time of repair. Next would be an injury to the scrotum or an scrotal trauma. It generally occurs in a blunt mechanism. It injures the testes, epididymis, spermatic cord, and hematomas with subsequent ecchymosis are common with such injuries. So, testicular rupture occurs with fracture of the fascial coating of the testicle called the tunica albuginea. So, this may occur via a blunt or penetrating mechanism. So, it's like this, having a broken egg. That's how testicular trauma or a scrotal trauma happens. So you can see here, this is the normal testicle with a well delineated capsule of the testicle, and on this side there's an injured testicle with formation of hematoma with disruption of the capsule. And also with this one, it's like a floating testis already, with hematoma formation surrounding the testis, and this is the epididymis. So the highest reported sensitivity for testicular rupture on ultrasound is 93%. So it is the most specific testicular workup to delineate trauma. So the highest, with the diagnosis of a testicular rupture, or when a high index of suspicion is present, especially with penetrating trauma, exploration should be performed. So testicular salvage rates are high in modern times and involve suture repair of the site of rupture. So when primary repair is not possible, a simple orchiectomy should be performed if it's already non-salvageable. So that's it for now for our urologic trauma. See you again next lecture.